All right, well, thank you, Maya. I really appreciate inviting me in for those kind words. And you guys all went out to eat lunch, and now I'm talking about morbid obesity. It's unbelievable. Okay, so let's talk more. All right, so our learning objectives. We're going to discuss reasons for the increased prevalence of obesity in the obstetrical population. We're going to discuss the consequences of maternal obesity, and we're going to discuss the anesthetic management of maternal obesity in a labor and delivery suite. Now, when you talk about how the pregnant parturian is different from the normal adult, you always talk about the physiological alterations of pregnancy, and it is definitely a major concern. And what I like to think of the differences is like the three amigos or the three A's. It's always airway, apnea, and aspiration, and that's what makes things different from a normal adult. Airway, we all know that it's more difficult to instrument the airway. There's an increase in the Mallampati classification. You're more likely to go apneic under periods of hypopnea, and you're more likely to have aspiration. After 16 weeks gestation, you need to do supine left uterine displacement because of supine hypotensive syndrome. There's a decrease in MAC for most of the anesthetic agents, and advanced maternal age, as well as morbid obesity, all adds can complicate management in the parturian. Now let's talk about the epidemiology. Well, it's a worldwide epidemic, and in fact, the term has frequently been used, globesity. It affects about 66% of the U.S. adult population, and this graph, this circular graph, just basically shows that healthy adults is around 33%. 66% of all the adults are either overweight or obese. 50% of women in the United States of reproductive age are either overweight or obese. The prevalence has doubled within the past 10 years. The prevalence it's more likely in the socioeconomic group, so it's higher in the Black population than the Hispanic, than the Caucasian. Prevalence decreases with increased education in nulliparity. Women with a high BMI before pregnancy, and this is what's worrisome, is that if women gain the weight in pregnancy, they're more likely to retain it. So in future pregnancies, it can add to the complication. It is the fastest growing health problem in the United States. It is definitely the disease of this millennium and of this century. And one thing that I got out of doing a literature review is that, you know, when you go into a room and you ask, what's your height and weight? And you're like, are they really telling me the truth? Are they really saying, is that their real weight? Well, one of the literature I got was that 84% of reproductive age women give the correct height and weight. So that's good. That is definitely a good thing. Now, I'm sure you've all seen this here, where this is the population of the states that have either obese or overweight, and you can see in 1987 hardly anyone is in the greater than 30% group, but as the decades go on, they're getting more obese. Now, here's the obesity trend, same type of deal. 1990, they're all blue states, sort of like the Democrats, and then now it's all red states, sort of like the Republicans, so it's definitely a problem. You know all about the medical complications of obesity. It's multifactorial, it's multisystemic, so all kinds of problems that can occur. Morbid obesity, it's a significant risk for surgical respiratory complications and also infectious complications. There's an increased risk for concurrent medical problems. I'll talk more about that later. There's an increased labor complications. I'll also highlight some more later. And there's an increased incidence of DVTs, hypoxemia, wound infections that all occur with pregnancy. And then there's also technical difficulties, not only with airway management, but also with neuraxial anesthesia. Morbid obesity accentuates the physiological changes associated with pregnancy. It's not uncommon that morbid obese patients can have left ventricular systolic and diastolic dysfunction. They can have pulmonary hypertension, obstructive sleep apnea, and also I alluded to the technical difficulties with regional anesthesia. So not only morbid obesity can you run into problems, but look, this slide just basically shows about the concurrent medical problems, hypertension, diabetes, DVTs. And this just shows that with the increase of obesity in the United States, so too do you have the increase in diabetes as decades roll on. So it is definitely a major problem. Now, if you look, this slide just shows that if you look here, I think this is 1990, the incidence of obesity is around 12%. So as it increases, we're up to over 25, close to 25, 30% up here. And this is the percent in the maternal population, and it correlates just with the general population. So it's definitely a correlation. Now, just because you're pregnant doesn't mean you get extra weight classifications or BMI. You're still considered a normal adult. In 1990, the Institute of Medicine, ACOG, the National Institute of Health, and the WHO organization all pretty much define obesity by BMI, which is the weight in kilograms divided by height in meters squared. And here's the normal. So that's 18.5 to 25, and you've got all these classifications. Overweight, you're over 25 BMI, obese 1, obese 2, morbidly obese greater than 40, and super obese greater than 50. Now, obesity complicates up to 28% of pregnancies. And in fact, patients with a BMI greater than 40, they're at greatest risk. And I'll show you, I'll have more to talk about that on the next continuing slides. Obesity risks in pregnancy. Well, one of the risks is subfertility, and they think that it's ovulatory dysfunction. Polycystic ovarian syndrome, so you're more likely to have miscarriages, increased time to pregnancy, increased risk for miscarriages, increased risk for preterm being preeclamptic. And in fact, as you put on the weight, the risk even can double for each 5 to 7 kilograms per meter squared. They're more likely to have hypertensive disorders of pregnancy, cardiac disease, gestational diabetes, multiple gestations. They think that's because of an increase in FSH levels, congenital malformations, postpartum pregnancy, operative vaginal delivery, increased rate for C-sections, increased risk for gestational babies, prolonged labor, more likely to have labor augmentation with the Pitocin, early amniotomy, stillbirth, increased risk up to 42% for UTIs, thromboembolism, and obstructive sleep apnea can complicate the pregnancy. So what about these pregnancy complications, and what are the risks? Well, if you have gestational diabetes, your risk is 3.6 times more. The odds ratio for gestational hypertension is 3.4. Cesarean section, 2 times more. Postpartum hemorrhage, 1.4. And macrosomia, odds ratio, 2.1. And not only is it, you talk about the odds, but if you look at this, it actually separates based on their classification. So here's overweight, here's obese 1, obese 2, and this is a BMI greater than 40. And if you look at diabetes, the more overweight you are, the higher in classification you get, look at these risks. So the adjusted risk ratio is 4 times more. So 4 times more for gestational diabetes. You can see hypertension, induction of labor, you're more likely. A normal vaginal delivery, well, that's more for if you're underweight, you're more likely. And that goes along with that you're at increased risk for instrumental vaginal delivery, also for an elective C-section and emergency cesarean section. So what about morbid obesity in labor? Well, it prolongs labor, and in fact, prolongation of the active phase of labor is more so than the second stage. Your increased risk for labor induction, decreased risk for VBAC and trial of labor after cesarean section, increased risk for macrosomia, shoulder dystocia, and malpresentation, increased risk for postpartum hemorrhage, 4th-degree lacerations, increased in cesarean section rate. And I thought this was interesting. The hospital stay. Look at this, 4.4, 3 more days that on average that a morbidly obese patient is likely to stay. It also, not only is it staying for the mom, but look at this NICU admission rate. So increased risk, 3.5 times more likely to be admitted to the NICU. And we all know that complication it's definitely increases with the cesarean section as opposed to just normal vaginal deliveries. Now this slide over here just basically shows that as your BMI, if you look over here, your BMI is over 40, that the percent cesarean birth is all the way up to 43%. So there's a linear increase in your odds for having a cesarean section. Now what about perioperative concerns? Well, emergency delivery, prolonged incision and delivery interval, so it's not uncommon if a normal section would last an hour to go 2, possibly 3 hours. And postpartum hemorrhage, and they had a nice panel discussion as to why. What are the reasons for why is it postpartum hemorrhage? Well, one of the things they think of is that there's macrosomia and also an increase in volume of distribution in the morbidly obese patient, which means that there's less bioavailability of uterotonic agents to act. Your increased risk for post-op infection, wound infection, and dehiscence, episiotomy, and endometritis. And one of the reasons they think is because there's poor vascularity in the adipose tissue. So because of that, you're increased likelihood to have seromas and hematomas. So they do recommend that you do close the subcutaneous layer in these patients. Also, postoperative complications such as pulmonary, and we also talked about clotting and the increase in thromboembolism rate. Now, what about breastfeeding? There's a problem with breastfeeding too. There's an increase in failure to initiate lactation. There's a decrease in lactation duration, and the mechanisms is they think it's alteration in the hypothalamic pituitary gonadal axis. And there's also a decreased prolactin response to suckling. So all these lead to the problems with breastfeeding. Now, if you look at, so we talked about the mom, well, what about the baby? What about congenital anomalies and birth defects? And look at these odds ratios. Neurotube defects are increased, spina bifida, cardiovascular anomalies, septal anomalies, cleft lip, cleft palate, anorectotresia, hydrocephaly, and limb reduction anomalies. Those are all increased in the obese parturient. Why? Well, one reason is that they think that it's more difficult to detect with perinatal ultrasound. So when they're getting these assessments that you just can't see as you would in the normal parturient. So like we talked about in the obese parturient, there's different classifications and there's an increased risk. So the birth weight, you're more likely to have a birth weight less than 2.5 kilograms in the underweight, but because of obesity, you're more likely to have macrosomia. So birth weight greater than 4 kilograms. It's much higher in the obese, morbidly obese category. Also, need for resuscitation, higher. NICU admission, higher in the morbidly obese patient. So what about proper equipment considerations? So you have to do a C-section or you have to take care of these patients. There's problems. You need the appropriately sized blood pressure cuffs, difficult and adequate IV access. We know we all treat these patients where it's so hard to get an IV in. You need longer fetal monitoring straps. How about the bariatric beds that are able to withstand all the weight and doesn't fall or have problems? And then you also need those side attachments so that when you do left uterine displacement that they don't fall over. Also even having hover mats available because you don't want to break your back in trying to move these patients. You need longer and larger OR instruments and sequential compression stockings for prevention of DVTs. So, question to the audience. Should there be subcutaneous adipose layer closure during cesarean section? Absolutely. And one of the reasons is well, it's not routinely done, although I think it's getting to be done more frequently. Well, there is evidence that if you do have closure with at least 2 centimeters of sub-Q adipose tissue, that you can decrease the incidence of seromas and decrease the overall reduction in wound disruption. But there is no difference in the rates of hematoma formation or infection. Now, how about staples? Should staples be used in the obese parturient? Yes, they should be. And the major advantages are a decrease in infection. They're less likely to obscure wound drainage, and one of the things they talk about is when you get those seroma formations, instead of disrupting the whole suture, all you have to do is take out a couple of these staples, and then you can allow drainage without opening the entire wound. Another question, should monofilament sutures be used? Okay, here's the answer. Well, it's a sort of yes and no. Advantages with monofilament sutures is there's less tissue drag and there's no internal spaces to harbor bacteria. But one of the disadvantages is that it's weak if it's handled roughly. It's harder to handle because if you do have, you know, how they slide and stuff. So, and also there's less knot security. So those are the advantages and disadvantages. Now, what about maternal mortality? So the national MMR, I think Dr. Buckwick said it would drop down to like 11.2 or something like that, so it's around that range. The confidential inquiry maternal at the CMAC, what their inquiry in 2007, that obese patients, 67% of direct deaths attributable to anesthesia occurred in obese parturients. And then we all know about the Michigan series from Jill Meyer et al., where they had 8 anesthesia-related deaths. There were no deaths with induction of general anesthesia. 5 of the deaths occurred with emergence, extubation, or recovery. And they speculated that lapses in postoperative monitoring, supervision contributed to 5 of the 8 anesthesia-related deaths, and other characteristics that are really important that they thought was important to these deaths was obesity, 75% of the patients had that, and also African-American race. And I believe Dr. Suresh is going to talk more about that later, and hopefully I didn't steal her thunder. So I don't think I did. All right, well, what about anesthetic management? Well, obesity has an additive effect to all the complications. And we alluded to earlier, we talked about the incidence of difficult airway. Generally, it's quoted to be 1 in 150. Difficult intubation with failed intubation is supposed to be around 1 in 280 versus the general population is 1 in 2,000. So it's a logarithmic 10-fold increase. You can get respiratory obstruction post-extubation. And we talked earlier about the neuroaxial replacement rate. Not only is there a problem with the initial epidural failure rate, some studies up to 42%, but there's also an increase in frequency of multiple neuroaxial attempts to try and get that epidural and spinal in. There's an increase in the epidural replacement rate and also an increase in invert and dural puncture. And then we all know about obstructive sleep apnea and given narcotics and sedatives afterwards, so that can cause some problems. And there's an increase in perioperative morbidity, near-death episodes, and also death. Now, so this patient walks into your OR for a cesarean section, and you know, I know how you feel because I know how I feel. So, so it's definitely not going to be whatever, a run in the park or walk in the park. So what are the advantages? And we talked about this earlier, and it was alluded to, that epidural and CSC advantages. The big advantages of doing a CSC, or at least having that epidural component, is you can titrate the local anesthetic. You can extend the block duration for the surgical procedure. You can do, in patients that are compromised in some certain way cardiovascularly, you can control the hemodynamics much better. And there's a decreased potential for excessive motor block, and you can also use it for postoperative analgesia, because you talk about that there are complications. Remember I said that up to 4.43 days they spend more often, so you want to get them out of bed to the chair. You want them breathing. So if you can provide that postoperative analgesia, that could be helpful. So this was also alluded to this morning. Question, what about spinal and epidural dosage? Is it the same for spinal bupivacaine? Is it the same for epidural bupivacaine? Well, for spinal bupivacaine, and Brendan, I believe, is in the audience, and it is highly variable is what you got it. But basically, what I got out of it when I read the article was that the ED50 and ED95 is essentially the same. There's big crossover in the 95% confidence intervals, so it's essentially the same. What you do want to worry about is if you give too low a dose, that it can wear off. Now, what about epidural bupivacaine? Do you decrease the dose? Well, morbidly obese patients require less epidural local anesthetic for labor analgesia with a higher initial block level, so you need to be careful. So why is that? Why do they have a higher block level, and why can they run into problems? Well, they think that the presence of epidural fat, increased venous distension from the aortic cavo compression can all lead to increased encephalid spread, so they're more likely an increased risk for hypotension and respiratory embarrassment. So it is a compression effect. Now, so you walk in and you see this patient, and we've all been there. So you can see the problems that can happen. Even if you're lucky to get the epidural in, there's problems that can occur. Now, if you look here, and remember I talked about the seroma formation, and then you can sort of see that there. Well, first of all, this definitely wasn't at my institution because we should be wearing gloves. You can see the seroma, just drainage right here, and just to have the retraction so that you can make a fan and steel incision is almost difficult. Other problems, and you can look at here, so the retraction devices to try and keep it open, so that can compromise and it can accentuate the cardiovascular problems that's associated with the neuroaxial blockade. Now, what about induction and general anesthesia? Well, there's a 17-fold increase in complications. That you know that they're already full stomachs, so you need to be careful with that, and aspiration. Supine hypotensive syndrome can be exacerbated, and if you have to hurry up and do a quick induction, that you know that 4 vital capacity breaths is essentially the same of breathing 3 to 5 minutes of 100% oxygen, although they do desaturate more quickly if they do to 4 quick vital capacity breaths. Be careful with the narcotics and sedatives. There are aspiration risks. Shoulder rolls and or pads is really important so that you can line up the axes. You could use the reverse Trendelenburg positioning. So rather than have gravity cause problems, just doing reverse Trendelenburg can increase that FRC, and it can give you more time so that they don't get apneic. 2-person ventilation, have the difficult airway cart in the room. We all know that they desaturate more quickly, and there's possible that they may need an awake fiber optic intubation, and if you need to do that, that needs to be done. You don't want to compromise both the mom and the baby. And also Plan B and Plan C, so LMA, have the glidoscope, have those available. Now, here's how you've all seen these slides, and this is just lining up the axes. You have the oral axis, you have the pharyngeal axis, and the tracheal axis. And just by using the head roll, you can do that. They talk about using the troop elevation pillow, and that's what you see that there in that slide. So that can be helpful to line up your axes. And I really like this study by Rao et al. And what they did is, and this is for gastric bypass patients, and what they did is they have these blankets, and how they're trying to line up the external auditory meatus with the sternal notch, and that lines up your axes. And just by flexing the bed, you're able to do that, and you can put a little bit of rolls underneath the head, but that essentially does the same thing of aligning your axes and optimizing your intubation. What really is hard for me is that if you're going to do this, that once they're asleep, to get all those blankets out from under their shoulders, so it can be really difficult. So I really like using flexing the bed, and when I have residents ask me, oh, I've never used this before, then I'll just pull out that article and give them some nice reading material. So what about extubation? And remember we talked about the Michigan series where you had problems with extubation and recovery and emergence. So you want 2 experienced anesthesia providers in the room. Reverse Trendelenburg position. Use PEEP, positive end expiration pressure, so that you can expand those atelectatic areas. You want to limit your narcotic use, give full neuromuscular reversal, and you want to make sure that you extubate fully awake and alert. So just because they're grabbing at the tube doesn't mean that they're fully awake and alert. So you want them to respond to commands, open their eyes, raise their head, and they can get negative pressure pulmonary edema. So when those vocal cords, when they collapse and they do an inspiration, that's how you can get negative pressure pulmonary edema. Two-person mass ventilation, so you want competent people in the room when you do extubate. And going to the PACU or going to the recovery area is not a failure if you're on a T-piece. So at least you have that you can breathe for that patient. So consider nasal mask or CPAP, and you want to recover an appropriate area. Taking them back to the labor and delivery room is not the right place. You either need to go to a PACU or the OR PACU or an ICU, so that make sure that the personnel are trained and they can actually take care of these patients. Now, what about post-op considerations? And I don't want to talk too much and steal our thunder, and I'll go quickly through this. But there are increased risk for respiratory failure. And one of the problems is that when you, especially if they have obstructive sleep apnea, and you worry about REM, rapid eye movement, and you really, you don't get REM rebound until the second or third day post-op. So you need to be careful. So you want to do the aggressive treatment and get them breathing so that you don't get into problems. So early ambulation, so prevention of decubiti and DVTs. And you might want to consider low molecular weight heparin so that they don't get these clots. Now, what about gastric bypass and banding? There's a lot of parturients that after these procedures, they're getting pregnant. So one of the things is that weight loss, if you can lose weight after gastric banding or gastric bypass, you can significantly decrease the pregnancy-related complications, the comorbidities. So the hypertension, the diabetes, they all decrease and they all get better. And it also improves fertility, so they're more likely to get pregnant. But they do recommend that after these procedures, you should wait at least a year, 12 to 18 months, because that's the period of rapid weight loss. And the difference between gastric banding and gastric bypass is you'll lose much more weight faster with the gastric banding, or I'm sorry, the gastric bypass. Now with the banding, it takes almost twice as much time to lose the same amount of weight. And because of the gravid uterus, as it increases in size, you have to worry that they might have, they might need to get that banding adjusted. So it's not uncommon. So what are guidelines for weight gain in pregnancy? So here's the guidelines, and then if you're morbidly obese, greater than 29 BMI, that you really are recommended only to gain about 15 pounds. And if you're low, underweight, you should gain up to about 40 pounds. So definitely you don't want to gain as much, and you would be more likely to retain it afterwards. So key points. Well, overall, you want to decrease the length of hospital stay. You want to decrease the infection rate. You want to prevent thromboses and clots. You want to identify comorbidities related to obesity so you can go ahead and treat those, and you want to improve neonatal outcomes. Now, what about anesthesia? These type of patients that are super morbidly obese, you really want to consider delivery at a tertiary care hospital. You want anesthetic and obstetrical consultation when they're ruptured and ready to deliver and, you know, ready, having problems and in pain. That's not the time to take care of their problems. You want to get them early. You want to ensure an early labor epidural placement and adequate functioning so that you can go ahead and use it. You can dose it. So if they need to go for a stat section, you have it. Surgery can outlast the procedure. So I talked earlier today about using a CSE or having an epidural, and you want to expect, anticipate, and prepare for preoperative, operative, and postoperative complications. And that's my first lecture. Oh, Winston Churchill said, when you get to the end of your rope, tie a knot and hang on. And this is your rope right here. So, okay, thank you.